Hi there. I'm Dr. Derek Vaughn. I'm a hand and upper extremity surgeon at Titletown Sports Medicine and Orthopedics at Bellin Health. Thank you for choosing Bellin to be your provider for work injuries. And today I thought we would talk a little bit about workplace finger injuries. It's a very common injury that we see in employees, and understanding the principles behind how we think about them and how we treat them should help you get your employees to us in a timely manner. When we talk about finger injuries, the most commonly seen injuries are usually the result of a crush or a cut, a laceration of the finger. These are the most common that we see in our clinics. They can even sometimes be partial amputations. If there's a break in the bone or a cut in the bone and any of the other structures are injured, these can be considered partial amputations. And so when you have an injury to a finger, you can injure skin, the bone, the tendons, the nails, the nerves, or the arteries. Those are all the structures that we think about potentially repairing if they're injured. And it can be difficult to sometimes tell which of these are injured based on just physical exam alone. And so the first question we always ask when it comes to a finger injury is the finger perfused? And there are several ways to tell if the finger is perfused, but the most common historical way is the picture on your left. Pressure is applied to the nail bed until it turns white, and then the pressure is released to see if the blood flow returns to the finger. The problem with this method is if there is venous congestion, meaning the blood flow is not getting out of the finger. Blood may not be coming into the finger, but if blood's not getting out of the finger because the veins are cut, you can be fooled into thinking that there is capillary refill, which is what this is testing. And so the more appropriate way to check for capillary refill is indicated by this video on the right. A pen or a paper clip or some object is used to scratch and swipe along the finger, and you can see how the finger turns white and then immediately has the return of the nice pink blood flow, indicative with good perfusion of the finger. So perfusion is the first question, and if it's perfused, oftentimes a crush or a cut may need an x-ray. If there's a fracture or a break under the injury, we need to know about it. Because if there is a cut with a fracture, with a break, we typically would put the patient on a course of antibiotics, and they may need a formal irrigation and debridement, meaning washing out and cleaning out the wound to try and prevent an infection in the future. If there is gross contamination with dirt or some sort of substance, they should definitely be seen. And so when we talk about finger injuries, I mentioned earlier that flexor tendons can be injured. The flexor tendons are the ones that allow you to bend the fingers and make a fist. And the problem with these injuries is they can easily be missed. And if they're not addressed within a couple of weeks after the injury, it can be impossible to repair them. And there are options such as reconstructions, but it oftentimes will mean 2 or 3 surgeries to repair that tendon. And so the earlier we get to them, the better. And so I'm going to share with you some exams here in a few minutes of how to tell, is there a flexor tendon injury or not. If there is a break, if there's a fracture, we often will try and get them immobilized in some sort of splint or aluminum foam splint. Can be used for a single finger or a resting hand splint, maybe for multiple fingers. And then there's the case of the subungual hematoma with a fracture. And a subungual hematoma is a fancy way of just saying there's blood underneath the fingernail. And the way it gets there is from what we call a nail bed injury. The nail bed is the soft tissue that covers the bone that lies between the bone of the finger and the nail. And so if you have a break in that tissue and there's a break in the bone, then there is an open fracture or a compound fracture, as some people call it. And those typically need the nail removed. They need to be washed out, cleaned up, and the nail bed repaired. Occasionally the break will be displaced and we will use a pin in those fingertips. And so any patient that will let me, and if there's a fracture, I will remove the nail and repair the nail bed underneath. This is a picture showing what a subungual hematoma looks like, where there's blood underneath the fingernail. And so for this patient, I would get an x-ray to see if there's a break in the bone. And then I would offer them either taking the nail off and repairing the nail bed so as to give them the best chance of having the nail regrow, or allowing it to heal where it's at. Coming back to the flexor tendon injuries, these are videos of the physical exam. on how to determine if there is a flexor tendon injury. The flexor digitorum superficialis, or FDS tendon, is the superficial most tendon that allows the finger to bend at this joint. It's called the PIP, or the proximal interphalangeal joint. That PIP joint bends because the FDS tendon pulls it down. And so the way to test for that is shown in this video. To test FDP, to test FDS, hold the fingers that you are not examining down and ask the patient to bend the finger. And as you see in the video, only the PIP joint flexes. The DIP joint does not flex when the other fingers are isolated. And then the FDP tendon, you want to isolate just the finger that's injured and see if they can bend. Examining in isolation just below the DIP joint and ask the patient to flex the finger. And you see that they share muscle bellies because the other fingers move. So you isolate just that finger and make sure they can bend at the DIP joint. If they can do those two things, it's highly unlikely they have a complete flexor tendon injury. But I still am always happy to see them to sort of confirm. Other things to look for when we talk about tendon injuries and finger injuries are the positioning that the finger can take if there are injuries. A swan neck deformity can form if the DIP joint is bent and the tendon is injured going to the DIP joint. And so seen on this picture on the left, that can be the result of what's called a mallet finger, where you have an extensor tendon injury, the tendons that extend the finger straight. If those are injured at that DIP joint, it can cause the finger to bend. And as the tendons become imbalanced, it can cause hyperextension at the PIP joint of the finger, and it can take on this characteristic swan neck deformity. These often don't require surgery, but they do require a long period of splinting to try and keep the finger in a good position while the tendon attempts to heal. They will often have persistent lag or inability to fully straighten the finger after treatment for this, but the earlier you start the treatment and the more compliant with treatment patients are, the better they do. Another type of finger deformity that can result as an extensor tendon injury is a boutonniere deformity, which is seen on the right, where the PIP joint, rather than extending, is actually flexed, and the DIP, the distal joint, extends. So it's essentially the exact opposite problem of a swan neck deformity, but it can result as from a tear in the central slip, as is indicated on the picture. This also may require splinting, and sometimes if there's a cut, we will actually go ahead and open up everything, wash it out, and repair the tendons as we can. And so if you see these sorts of posturing of the finger, or you see fingers that don't move the way they're supposed to, those are all reasons to get your employees to see us. And when it comes to amputations, not all fingertip amputations need a surgery. Historically, children were treated with repair and biological dressing, and it can work well in adults as well. This is an example of a patient that I had who had a work injury where the tip of the finger was amputated, and actually the skin and soft tissue that was avulsed or pulled off of the finger was sewn back on. And it's very clear that this tissue is not healthy. It's not perfused, as we showed. This is a very about a week out from the injury, looks like the fingertip is very necrotic. This patient was seen in an urgent care. They did a nice job of sewing the tip back on, but then the question is what do we do now? Do we amputate part of the finger? And not to bore you with the details, but it would be a pretty proximal amputation, meaning I'd have to probably take more of the finger than I'd really like in order to get the skin to close over the bone. And so after a lengthy discussion with this patient, we chose to see how it would go. We know that this can act as a biologic dressing and allow the finger to heal underneath. And about 8 weeks later, this is what his finger looks like. You know, it's a fairly normal looking finger, especially from the back. And then from the front, you can see that it's not got the exact normal contour that the other fingers have, but this is a pretty good result without a surgery that maintains the length of the finger. When it comes to finger amputations, there are very specific indications for whether or not to try and put the finger back on. The example I just gave you was a purely soft tissue partial amputation, whereas in a lot of our injuries, they're not purely soft tissue. And so a true finger amputation where we do a replantation, the criteria are very strict. Smokers have a high risk of the blood vessels that we have to repair clotting off and not allowing for good perfusion of the fingers, as well as with patients who have any history of vascular disease. And then contamination. If there's gross contamination of the fingers, they're at a very, very high risk for infection and problems. And when we talk about replantation, the results, unfortunately, are not always that great. A lot of times it's a stiff, painful finger that is not very functional. And a lot of patients will oftentimes do better if it, even with multiple fingers, sometimes they do okay with things such as prosthetics. But one of the indications for a finger replantation is multiple fingers that are amputated to try and give the patient a chance to develop as much of a normal hand as possible. We want to get to these. If the finger's been off for more than 12 hours and not been chilled, then we've run out of time and it won't be a viable finger anymore. And so if someone does have a finger that is amputated at your workplace, our recommendation is to wrap it in a cold, in a piece of paper towel that is moist. Wrap it in a moist paper towel, put it inside of a Ziploc bag, and then put that Ziploc bag inside of another Ziploc bag filled with ice. That's the safest way to make the finger cold to preserve it for a longer period of time. So the indications for a finger replantation, it must be a sharp amputation. Snow blowers, lawn mowers, some of the other ways that fingers are avulsed or pulled off are not suitable for replantation. A thumb at any level, oftentimes we will try, if it's more proximal, especially to the DIP joint, we will attempt a replantation because the thumb is so vital to function. Multiple fingers, as I said before, and any amputation in a child, which should not be as applicable for our employers, but is just a consideration. When we talk about evaluating a finger, whether or not a replantation will occur, we look for signs of avulsion. The ribbon sign is when you see that the blood vessel is curled, like it is in this picture, or this red line sign. That's where the blood has sort of escaped from the blood vessel along the length of the finger. You know that those blood vessels are not good blood vessels. Blood vessels almost have to be very sharply cut in order for us to be able to repair them and hope for any meaningful perfusion to return to the finger. And then finally, I just want to make a quick mention about infections. Anything can become infected. Anything can become infected as a result of a work injury or a surgery. And so we're very, very meticulous in keeping a close eye on our patients and hope that you can help us with that with your employees. And so who are you going to call? Call us, the hand surgeons, because infections can get out of control very quickly. If you suspect an infection, please get your employee to see us. Sometimes just throwing them on antibiotics can cloudy the picture. And sometimes it's better to hold off on those, especially if it's something that we think may need a surgery, because then we can get a better idea of what bacteria is causing the problem. I have a few things here that typically don't apply for most of our employers, but are good reminders for some of our occupational health and urgent care folks in best ways to treat dog, human, or cat bites. Those are common infections that we see, but those antibiotics can also be helpful in injuries to the hands. And Keflex is a very safe antibiotic that we often use in the early time period if there are open wounds and open finger fractures and under the care of a surgeon. To give you an example of how quickly an infection can progress in a finger, this was on December 3rd. And if you remember back to our deformity of fingers, this finger sort of has a swan neck deformity, which gives us an indication that the tendon likely is not competent to the distal interphalangeal joint, the most distal joint of the finger. And you can see that finger is taking that swan neck posturing. That was on December 3rd. And just 1 month later, you can see that the bone has essentially eroded away and the joint dislocated from an infection in this finger. And so this patient was treated on antibiotics for the entire month between December 3rd and January 8th, and yet the infection progressed in spite of that treatment. And so the quicker you get folks in and not letting those sort of things linger, typically the better the outcome and the more options we have to treat them. I hope this has been a helpful review of finger amputations, finger fractures, finger lacerations. I hope this will help you better evaluate your employees and get them to us in a timely fashion. And as always, if you have any questions, please feel free to call. get in touch with us and get us over to get your patients over to our Title X clinic. We do have a free walk-in clinic where they will be immediately evaluated by our athletic trainers. And for most of the injuries that we've discussed today, those athletic trainers then get them in to see either myself or my partner, Dr. Goldberg, on the same day. Thank you for your time, and I look forward to working with you.